Alaikum everyone. This is me, Dr. Mohammed Ali Bashir. I'm from the Committee of Sudanese Doctors in Gulf. During this pandemic of COVID-19 all over the world, our committee are continuing to provide some services and some activity that we are trying to support our people and support our colleagues as a medical teams in Sudan. So I'm glad and blessed today to have with me my friend and my colleague, Dr. صديق الفضل. Dr. صديق الفضل, he is a senior specialist of laparoscopic and general surgery, and he's a former teaching faculty staff in Islamic University, Durman, Sudan, and he's currently working as a senior specialist in military hospital in Saudi Arabia. Welcome, Dr. صديق, and thank you for being with us.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله تعالى وبركاته. وشكرا جزيلا الأخ دكتور مهند علي. وشكرا لكل الحضور. بنرحب بكم في هذا اللقاء المتواضع البسيط في جزء من أنشطة جمعية أطباء الخليج، وكما ذكر الدكتور مهند التي تهدف إلى رفع الوعي حول جائحة كورونا 19 وتحسين الممارسة العملية من أجل حماية المريض وتقديم الخدمة الطبية المثلى والأفضل، وفي نفس الوقت حماية الكادر الطبي الممارس. ما حنتكلم كثير، حيكون عندنا كلام مختصر شديد عن practical guidelines بتتعلق بالsurgical practice during the COVID-19 time. So let's start. And our scope of this presentation is to I think there is some technical issues. Just let me fix that first, and we will continue, inshallah. I'm not able.
Yes, very good.
Yeah, now it's okay. Now it's all right.
Yeah.
So our scope of this presentation is to have guidelines. As I mentioned, these guidelines are meant to protect our patients and to protect the surgeons and to protect the staff and all medical community at large. In this part, we have main three categories. The first one is to the restructuring of the surgical service and surgical practice, because we know this COVID-19 is exponentially spreading disease and it's highly contagious. And if we do not follow a certain structural measures, maybe we will lose our staff and we will lose our teams and we will not be able to provide the service in a very short time. So we have to restructure our system, and we have to restructure our service so as we can cope with the staff loss, for example, or staff isolation. There will be a very good arranged backup for providing a minimum accepted service, especially if you are considering our homeland, our country, with a very shorthand in everything, shorthand in staff, shorthand in equipment, shorthand in PPE materials. And so there are a lot of shorthands. We have to put them in our mind. These guidelines and these structures are based on a best available evidence. We revised the American College of Surgeons, we revised the NHS guidelines in Europe, and we revised the Saudi guidelines for infection control here in our institution. So we try to summarize all these guidelines together, and we tried to put them in this presentation. So before we go forward, let me start my presentation with an opening scenario or opening case scenario. This is just to make, to put you in a little bit adrenaline of surgery and to get your attention, make you more hot. This why, because we are surgeons, and the question why are we considering the COVID-19? Does it has anything to do with surgery? Does COVID-19 has any mimical surgical presentations that looks like surgical emergencies? So I will present this. This one of the papers that I mean the case presentation that published in the internet. It's available, and I put the link down. You can follow that up. She's a woman with acute abdominal pain. She was admitted to the hospital with suspected cholecystitis. In addition to the abdominal pain, that woman, she had vomiting, she had loss of appetite, she had diarrhea, and symptoms of pyrexia. If you consider this together, abdominal pain and symptoms of GI function loss, she has a loss of GI function in terms of anorexia and nausea, and she has abdominal pain. So this is a classical presentation of acute abdomen for any surgical patient. But this lady, despite she doesn't have any symptoms related to the respiratory tract, later on it turned to be a COVID-19 positive patient. And what makes the surgeon think about the possibility of that she is having COVID-19, the findings encountered in the CT that is done for acute abdomen. She presented acute abdomen, they did good history, they did good clinical examination, they did for an ultrasound abdomen, but they failed to establish a clinical diagnosis for that. So they step forward for a CT abdomen. And as we know, the CT cuts involve the lower part of the thorax and the base of the lung. This is what they found. This is what they found in the CT. So they saw that this lady might have something related to COVID-19 disease, and they step forward for testing that lady, and it turned to be a positive case. Followed this lady, same scenario with acute appendicitis, mimicking picture, with acute diverticulitis, mimicking picture, with a patient with non-specific abdominal pain. So they provide a series of 5 cases. All of these cases, they presented with features of acute abdomen. And they tend, despite they don't have any respiratory symptoms, they tend later to be a COVID-19 positive cases. So I'm presenting this case to raise the awareness that there are common surgical symptoms that might be the initial presentation for a patient with COVID-19. These symptoms include 31% of the patient they present with primarily GI symptoms: abdominal pain, loss of appetite, nausea, vomiting, some loss of, some also have had diarrhea. And not to forget, 40% of the patient, they have elevated liver enzymes. None of the patient we mentioned have a respiratory tract symptoms. And all of them, they have a CT findings consistent with COVID-19, and they have approved laboratory tests that also positive for COVID-19. So behind this trigger, behind this warning exercise, the message is that early suspicion of COVID-19 is very, very crucial for early diagnosis and reducing the risk of transmission. Because if you are dealing with a patient at an acute abdomen without suspecting COVID-19, you might not follow the proper infection guideline protocols, and you might not put on your PPE, so you will be exposed, and the other patients will be exposed. You will put the patient in a common room or a common ward. So it's better to have early or high index of suspicion for any patient who presented with because this presentation is highly oriented towards surgery, we don't want to go for the part of the infection control, and we don't want to not to forget to mention that there should be a triage, and there should be a process for selecting the patient, and for the procedure for early assessment of risk of infection should be followed up. So now we are in the core of our presentation. The first part of this presentation, the triage of non-emergency surgery. This is the adapting surgical services, restructuring of the surgical services. It starts by triaging of non-emergency surgery. We know in all the world, if you consider Britannia, if you consider America, if you consider the wealthy countries with good resources, with good resources, whether human resources or structural resources, despite all this, they halted all the elective procedures. They postponed. In the NHS, halted the elective procedure since 15th of March. They are no longer carrying any kind of elective procedure. So we should postpone every single elective procedure, and to make our focus to treat only the critically ill patients and the emergency cases, so as to have a good reserve of staff and to have a good reserve of supportive and structural needs. So the question pops out, how can I triage the patient? How can I determine whether this is an emergency that needs to be treated, or whether this is an elective? There should be a guidelines for this, and we are following the National Confidence Inquiry into Patient Outcome and Death. This is a well-known body, and it's part of the NHS in UK. And this body is responsible of providing the service, putting the guidelines, and prioritizing the patient according to their needs. So they have the patient categorized into 4 types of patient. Immediate patient, those who should receive the service within minutes of time after diagnosis, and urgent cases, those who should receive the service after, like say, hours after establishing diagnosis, and expedited patients. These are those who need surgical intervention, but the pathology is not life-threatening, and it's not organ loss-threatening pathology. And lastly is the elective cases. These are the intervention plan for booked in advance routine admission hospital cases. So we cannot, if you ask the question, why isn't it possible to group operations? We cannot group operations and say that the certain procedures, they are, let us say, emergency procedures, and certain procedures, no. If we take a hemocolectomy, for example, it could be an immediate procedure if the patient presenting with life-threatening GI bleeding, and at the same time it could be an elective procedure if the patient presented with non-obstructing carcinoma, and between the two there is the range. You can, for example, splenectomy. It's an emergency if the patient presented with trauma and he's bleeding, and he might be lost because of shock and blood loss, but at the same time it is unelective. If he has a malignant hematological disease, so we cannot group the procedures and we say that certain procedures are highly should be done in an emergency setting or something like that. So the clinical acumen, the clinical judgment, the assessment of the surgeon and the surgical team and the multidisciplinary team, all of them, they collaborate their effort together and they collaborate, they work together to come out with a decision if this patient should receive an immediate care and this patient should be elected for an elective procedure. Okay. Part of adapting surgical services, we have to have other ways of providing the service. Restructuring of the system doesn't mean we do not provide the service to our patient. We should provide a good, optimum, proper surgical service to our patient according to their needs, following new modalities of providing this service. We can do clinical networks, we can do calls through cell phone, we can have text message, we can have connection with the patients through messengers, through Skype, through WhatsApp, virtual outpatient clinics. All these are scenarios which we can use. And today I saw a video for Dr. Mohammed Al-Fatih. I think he's running a cardiology clinic in Duman, I think, which is very, very proper way of providing the services, have a very good rapport and very good discussion with the patient. Even the type of medication she's taking, he is able to see that medication and he registered just through Skype. They were, so we can adapt our service. So can okay. Practice point: you should do all follow-up appointments by phone except when a physical examination is necessary. So that means there should be a phone for call. This a special line, which is hotline, which is 24-hour charge, and there should be a rota for that phone. Let us suppose we have a surgical team. We will come back to the specific structure. Like, let me give you an example just to tell you how we can do a follow-up through the phone. There should be a line, and this line distributed in the hospital gates, in the clinics, in the WhatsApp of the patients. So it should be distributed. And the patients call, and one who is senior, who is expert, will answer them, and then he assess them over phone. And according to that assessment, he will take a decision whether the patient come to the ER to be examined properly, or that clinical concern and that clinical complaint can be just managed over the phone, and you can prescribe even medications, you can prescribe remedies for the patient over the cell, and you can send this type of prescriptions in the WhatsApp. So the phone is there, the patient call, you answer them and you assess them, and you tell whether you can come to the emergency department or you can go to the pharmacy to take so and so and so. All right. When possible, you try to reduce or delay any number of radiological evaluations. We should raise up the ability of clinical assessment, and this is why in the era of COVID-19, the one who is holding the stakeholders of clinical practice is the seniors. We know that junior staff and resident and house officers, they are trying to help, and they are willing and they are very enthusiastic. But we would like to narrow the contact between the patients and the healthcare. So we have to have a very good decision maker. The one who is a good expert, he can make a good decision from, and that the decision is almost 100% safe. So it's now the burden will be over the seniors, very unfortunately. But we have a lot of work to be done by the junior staff. We will come to that later, inshallah. Prioritize oral and subcutaneous treatment above infusion-based treatment, because oral treatment can be taken at home. So try to make it oral as much as possible. Perform blood tests outside the hospital as much as possible. Have oral medications delivered to the patient home. If you have a very good, well-established healthcare system, you can deliver the medication to the patients in their priorities in their home, so they cannot come to the healthcare facility. So now we come to the restructure of surgical teams. We will not work by the system, the old system of units. You know, we are in Sudan. We have any hospital have multiple surgical units. Let us say 4, 5, 6, like that. We will merge all these units together. All the systems, for example, colorectal surgery, hepatobiliary surgery, foregut, endocrine surgery, general surgery, all of them, they will be merged together. And after we merge them, we try to make 3 clinical teams. Clinical teams, they are operating teams, they are inpatient managing team, and they are outpatient managing team. These are the three teams who should work ideally. Let us suppose we have 5 units. We will merge the 5 units together. The consultants, the senior registrars, the junior registrars, the residents, the house officer, all the staff should be merged together and divided into 3 main groups. These 3 main groups entitled like that. One of this group is dedicated to the OR. They just do the operation work. They have nothing to do apart from just carrying up the operations. If any patient who needed surgical intervention, they will carry out that surgical intervention. And after they finish the operation, they endorse the patient to the inpatient team. And this is the second group. And the role of the inpatient team is to do all the clinical work inside the hospital. Any surgical service that's needed for the patient who is admitted, it is the job of the inpatient team. And this inpatient team will do the daily rounds, will do the follow-up of the patient. They will document they will do the documentation for the patient, and they will answer the consultation from other disciplines, from internal medicine, from obstetric, from whatever other department that requested a surgical consultation. They will answer that surgical consultation. And here, this part can be done by the junior staff, because there is a plan which is already done and it's written, and they just want to follow up this plan, and they can communicate any new emerging symptoms or any new emerging conditions about the patient. They can communicate this to a senior one through the phone. And during the inpatient, not all the team do a regular, let us suppose the inpatient team is four doctors, with one of them is a senior resident. Not all of the 4 doctors will do a round, like a routine clinical round, like the way we did in the previous days before the COVID-19. No, the senior resident should assign every single one of this team to a certain group of patients, and because to limit the exposure of the team and to limit the exposure of the patient. Let us say Dr. صديق is assigned for patient A, B, and C. Dr. Muhammad is assigned for patient D, E, and F, and you got my point. So, and then they report to the senior house officer or the senior resident or the senior registrar who is leading the inpatient team. And we suggest the senior one, the one who is able to make decision again, as we mentioned before. Okay. This is just to rehearse what we mentioned. Inpatient care, this team performs all inpatient clinical duties, including daily rounds, new consultation, consult staffing, admissions, discharge, documentation, operating team. This team is responsible for coordinating the operative care of patients, and the clinical team. The clinical team is the team who do two things. Number one, they have the hotline. The one who answers the hotline is the clinical, is the outpatient team. Because the patient call you, you answer him, and you make a decision that that patient needs urgent assessment with clinical assessment and so forth. So you will advise the patient to come to the ER, and you should have one of your staff who will conduct the rest of the assessment. So the outpatient team have two roles. The first role, they should follow they should carry the online clinics, the Skype clinics, the messengers, the WhatsApp, and they answer at the same time the calls from the patient. And they will work together with the emergency department to cover any patient who come to the emergency department with emergent surgical condition. Okay, now in the restructuring of surgical team, we come to the rotations. As we mentioned, we divided the patients, we divided our team into 3 groups. Let us name them Alpha, Bravo, and Charlie. By the way, this is what's really practiced now worldwide. Okay, and these teams, Alpha team is inpatient care, Bravo team is clinical care, and Charlie team is operating care. They work in week 2. In week 1, in week 2, they will shifting will happen. You got my point. The operating team will come inpatient team, and the inpatient team will be an outpatient team, and every now and then we are cycling within these rotations. What is important to mention here, every team should be divided into 2 groups. The operating team should be divided into 2 groups, so they work the cover for the first 12 hours during the daytime, and the group B will cover the night shift, so not to exhaust and overwhelm our staff. Again, for the long term, we have short rotation and we have long term rotation, and we have inter-team rotation. Inter-team rotation, I mentioned that already. The operating team become inpatient team, and the inpatient team become outpatient team. The short team, the short rotation, I mentioned also that one of each team should be divided into 2 groups. One group cover 12 hours during the daytime, and the other group cover 12 hours during the night time. So for the long time, after 2 weeks, one of the team should have a rest. They should rest. They should rest for 14 days. Okay, and after 14 days, they have 4 days for social and family. We should not forget that, definitely. Suppose now you are working, you are the working team. You will continue the work for 14 days. After that, you will be isolated for 14 days. After the isolation period, you should have 2 to 3 days or 4 days for social and family issues. So as you will not burn out, if you are just running, cycling, work, you will get tired and fatigued, and you will develop a burnout syndrome. So there are 4 days. So the team will work for 18 days. 14 days work, and 14 days you are covering for your colleagues because they are doing social activities. And then when they come, also they hold up for 18 days, and like that, the work will continue. So in the case of staff loss or need of isolation, what should we do? Yet there are no enough or adequate experience to know what will happen to the service, but we suggest like that. The teams are larger than typical surgical units. Now we have 5 surgical units, we merge them together and we just make them into just 3 teams. So each team is a very big and larger team than if we compare them to a single conventional unit. Larger teams can better absorb a temporary loss of a resident. If you lose 1 or 2 staff, the larger team will absorb that loss. Larger team can function. What we mean by larger, a minimum 4 resident. This is larger. It's enough to work. By the experience and by the practice, we found that is more than enough. In scenario in which their entire team is lost and they need to be isolated, restructuring of the remaining 2 teams and dividing them into new 3 teams for the temporary loss of the staff. And after the isolated staff recover and come to start the work, and we go back to our primary restructuring. Well, adapting surgical services. Part of adapting this surgical service, if you don't want an orthopedics to put a tube inside your trachea, just stay at home, because we have to work beyond our scope as surgeons. We have to work in things that is not related to the surgical practice. We can participate in the management of acute respiratory team. We can help the ICU team. We can help in the triage team. So we have to have good preparation to work beyond our regular scope as surgeons. You can even do the cleaning. It's not that. I mean, you just prepare yourself for any single task that help push forward the service, the clinical service for the patient. Even you can be participating in caring for patient at the end of life, what's called hospice care. So in case of extended scope of practice, in such circumstances, we should identify the need, and this is not our job, but it's a managing the manager system. The managing system should identify the need and should provide appropriate training. If you are assigned to assist an ICU physician and you are surgeon, you should receive a minimum appropriate training that enable you to be a good supporter, not to be a burden over that already functioning system, and you come to them and you put much burden over them, and because you did not receive appropriate training. The need for you to work in the triage area, they should train you about triaging, how the triage is carried out. Team working and collaboration, and definitely surgeons may be required to clinically manage a patient with severe acute respiratory infection problems. So this is available online from the WHO guidelines and from the CDC guidelines. It's available and accessible for everyone who wants to make himself oriented about that. The second part of this presentation is protecting the workforce. Primarily, we restructure the system to provide the service to have a well-established and good working system that maintain the service during the COVID-19 period. But at the same time, we should provide some information about how to prevent the infection and how to ensure surgeons and surgical teams' well-being. Infection prevention, the common word, we work for you, stay home for us. Definitely we will protect yourself and you will protect us. As the pandemic accelerates, appropriate infection control practices should be followed up. Access to the right personal protective equipment. These two factors that are the main cornerstones for infection prevention. Number one, isolation, social distancing, home isolation. I mean, all the community should follow up the guidelines and the instructions from Ministry of Health. And within the team, we should have appropriate control infection practices, and we should have available on the hand PPEs. Especially during the aerosol generating procedures, like if you have aerosol generating procedures, you should have disposable gloves, you should have disposable fluid repellent gowns, you should have filter face piece type 3, and filter face piece type 3, this is the most protective one. It is 100% protective mask, and if it's not available, we can use type 2, and if it's not available, we can use N95. So you should have the highest and the very high standard one. The most appropriate one is FFP3. If it's not available, then FFP2, FFP1, and if all FFP not available, then we can use N95, because N95 the efficacy بتاعتها only 95%. So there is a chance of 5% you can get the infection, and 5% is not less, because you are a healthcare worker. Your loss is a loss of the whole service. If we lose a surgeon, we will lose surgical service. So we should provide the maximum protection possible. In the least, just a surgical mask. So what are the aerosol generating procedures? These are intubation, tracheostomy, bronchoscopy, upper gastrointestinal endoscopy, surgeries and post-mortem procedures. Any surgery is aerosol generating procedure, whether open or laparoscopy. Don't rush that. I'm just going to do an appendectomy, which is a very minimum procedure, and I'm highly technical skilled person and I can do it in only 7 minutes. No, it is still it is aerosol generating procedures, and you can get the infection from that patient. Some dental procedures and invasive and so forth. The important parts we should follow also during the transport of patients. During the transport, schedule the procedure as the last case in the list. Is it clear? Hospital security shall clear the road from ER to ward to ICU to OR. When you are transferring the patient from the emergency room to the operating theater, there should be no one in that corridor. The way to the theater should be clean, and this is the job of the security. البوليس اللي بيدق السودان ده وظيفته. To clear and to help and to facilitate the movement of the surgical team between the different departments, between the OR, between the ICU, between the ER, and so forth. Patients should wear surgical masks while they are transported. They should put on a surgical mask, and if this could not be applied due to clinical condition, except if it's not applied. But otherwise, every now and then, the patient should have a face mask covering his face. Transporting team should wear surgical mask. Don't forget, الناس العمال البسيطين اللي بيشدوا النجارة وودوها ديل, we should protect them. Because if we do not protect them, then after a few weeks, we will be the one who is carrying the patient. Transporting team should wear surgical mask, a clean glove, goggles, face shield, and isolation gowns. One of the very important practical points is the consent discussion. Where should I do the consent? Consent should be immediately secured in the place where you take the decision for surgery. Don't, for example, a patient come with acute abdomen and you decided to do a appendectomy. In the ER, in the emergency room, you should complete all the documentation, you complete all the lab work, you complete all the necessary imaging that is required, and at the same time, you should secure the consent at that level. And the consent should clearly include discussion about the possibility of getting COVID-19 from the hospital and from the theater, even the patient presented with simple appendicitis. Okay, and we take a decision to operate of them. Definitely, it's better to treat appendicitis medically if it is applicable. But let us say that we take a decision for surgery. Now we should discuss this with the patient. Say you can get the COVID-19 infection from this procedure. Despite we cannot guarantee your full 100% protection, so it should be included. If readily available, definitely testing for COVID-19 should be carried out. Intubation, extubation, all these procedures should be done in a negative pressure room, or if there are no negative pressure rooms, intubation, extubation, and recovery should be done in the same room where we did the surgery. The place you did the surgery, if you don't have a recovery room with negative, definitely we don't have that one in our setup. So let us immediately say that the recovery, the extubation and the recovery should be within the operating room. And if it is possible, there should be a one single room that is dedicated for any patient who is positive with COVID-19 disease. All non-essential or hospital office staff should be working from home. They should not come. Okay. Only those considered essential staff should be participating in surgical case. Every single equipment, suture material, suction devices, whatever you need, imaging, X-rays, C-arms, whatever you want, you anticipate you might need, you should prepare it beforehand, so you can limit the movement and you can limit the staff. Electrosurgery, I mean the diaphragm should be set to the lowest possible settings. Okay, surgical equipment used in a patient with COVID should have a separate sterilization cycle. Okay, operating rooms should immediately either to be dedicated to COVID-19 or after each single procedure they should undergo terminal cleaning. Okay. Well, this is the last slide, but not the least. We should ensure our surgeons and surgical team well-being. Make use of any support system available locally, such as reaching out to mentors, peers, and colleagues. Senior clinicians should also prepare and be willing to help. Mindful signs of symptoms of stress and fatigue. This should be clear to yourself, because you will notice it in your colleague. If your colleague is burning out, you should have some measures to help him cope with the stress. We all have stress. We are away from our families. We are away from our kids. We are deprivated from a lot of emotional things. So we have to have these things together. To take breaks, recharge, where possible, allow, take snacks, take jokes, tell jokes, enjoy yourself, enjoy your time, provide emotional support to each other. And رمضان كريم وكل سنة وانتم طيبين، وإن شاء الله السنة الجاية نشوفكم وانتم في أحسن حال. COVID-19 has been halted from the world and we are able to win the battle against that disease. شكرا جزيلا.
Thank you so much دكتور صديق. أشكرك جزيل الشكر. So we have some questions. So there is something written or something. Okay, so we'll take Dr. Mohammed Al-Noor. He wanna participate, or I think he's having questions. Dr. Mohammed Al-Noor. ممكن تعمل unmute من عندك دكتور؟
من عندي أنا؟
دكتور محمد نور. Yes, دكتور محمد نور.
السلام عليكم.
عليكم السلام ورحمة الله.
شكرا جزيلا يا مستر، والله يعني مهند شكرا لك، ومستر والله غطيت تغطية لطوبك مهم، والناس دائما السيرجري في كثير من الأحيان يعتبروا أنه مواضيع السيرجري الناس كلها تعتبر الكوفيد 19 ميديكال كيس، لكن هي في النهاية المريض whatever هو سيرجري ولا نون سيرجري هو مريض، فغطيت تغطية كويسة وجزاك الله خير. يعني أنا سؤالي we don't have negative pressure of course. We don't have negative pressure in the OR room. So in this situation we will especially through the intubation and extubation, in the induction of anesthesia and intubation, we will replace with HEPA filter. And another question, this HEPA filter, if we will replace with HEPA filter, will continue through the all the procedure, or the procedure of operation. We will let the HEPA filter work, or we will stop after the intubation immediately. So this need, because as we are, the OR is positive pressure, and we are in panic with the team outside the rooms, because who are in the room with N95, we cannot get infection, but who are outside the room with this positive pressure, high risk. What your comment, Mr.?
Clear, Dr. Mohammed. Thank you so much. Appreciate it. دكتور صديق.
المشارك اسمه محمد.
دكتور محمد نور.
دكتور محمد نور، شكرا لك على سؤالك، سؤال طيب جدا. سؤال very specialized. الناس الانفكشن كنترول لو موجودين معانا بيساعدونا كثير. احنا شغالين في ستراكشر طبعا في السودان، في بيئه طبعا definitely we don't have negative pressure rooms we don't have negative pressure lines. As you mentioned, the staff working inside the OR, they are protected because they are practicing the aerosol PPE droplets precautions PPE والايربون دروبلت الايربون precautions. لكن السؤال هل الغرفه نفسها بتبقى سورس لانها يبقى ينتشر منها الفيروس لسائر المستشفى؟ طبعا ده مساله بتاعت ستراكشر بتاع يعني تاسيس المستشفى نفسها. فلو الهيبا فلتر لو افيلابل it's better to be started before الاو ار تبدا. خلاص احنا مثلا حاليا لما الهيبا فلتر بنستخدمه حتى لو العيان ما ماشي جراحه، خلاص مثلا انا عندي عيان suspected any surgical diagnosis, he's not suspected COVID-19. I will give you a typical scenario practice. Last night we were doing a permacath insertion for a patient who is going to do dialysis catheter. It's a very simple procedure, it doesn't need anything. But in the room he is admitted in the general room without negative pressure. We put a HEPA filter like 15 minutes before we bring the patient in, and that HEPA filter was in continuous function until we discharge the patient from the room. You get my point? Yes. Until we discharge the patient from the room, the HEPA filter was functioning. So the same will be applied. If we are operating in a room without negative pressure and we have available HEPA filter, we have to stop the HEPA filter before starting the procedure and continue the HEPA filter until after the procedure finished and all the staff don off their PPE and like let us say 30 minutes one like that, 30 minutes after the procedure and after the cleaning, during the cleaning of the room. So this is what I can answer, but it's better to be addressed by infection control.
That's clear. That's clear. طيب Dr. Sadiq, that I have like a point that I want to just also discuss it with you, that what we are talking about, that maybe this is in the ideal situation, but sometimes in the worst case scenario, especially in Sudan, and the situation in Sudan and the availability of the PPE and all the infection control measures and all this stuff, usually we cannot have it like regularly. In case there is some ethical debate in one point, that in case we have an immediate case, immediate emergency case, like trauma or massive bleeding or whatever, and the surgeon in Sudan, in the institute that he's working, that for some reason that he's not having the full protective measures. And we cannot even obtain the history from the patient if there is any sign of, or whatever, of COVID or whatever. So what will be the situation right there? Because there is a lot of ethical debate in this area. Some of the surgeons, they will say, no, I will not go. Some of them, they will no, I will not, I will go and I will do whatever because I did and I have my oath. And what do you think?
اولا اتمنى انه
ما نخط في الحته زي دي، مش
ان شاء الله ما نتخط في الحته زي دي خالص
ان شاء الله.
ولكن هو ال provision of service is mandatory with the available resources. According to the available resources, we have to tailor the available resources and manipulate them so we can provide the service with the minimum risk to the patient first and with the minimum risk with the service provider at the same time.
Exactly.
So he can use, we saw a very nice modification of PPE. One of the, he make the regular surgical gowns and he covered them with plastic bags.
Yes.
With long sleeves of plastic bags like that. So we can try to manipulate the available resources so we can provide the service to the patient with a minimum risk for both the patient and the surgical team and the working team in general.
So clear, Dr. صديق. Dr. صديق, there's a question here in the Q&A from Dr. Samah. She's saying, COVID-19 positive patient with appendicitis, can we treat it conservatively related, or it's related to the severity of respiratory symptoms? And she's thanking you for the lecture. I think you went through this, but you can just clarify it a little bit.
شكرا دكتورة سماح. Generally, we try to treat all acute conditions, acute appendicitis, acute cholecystitis. We try to treat them medically as much as we can, and we have a lot of successful rate here since this time of COVID-19 started. Now we are treating the appendices and we are treating the cholecystectomies. We are treating them, I mean the cholecystitis, we are treating them conservatively and we are successfully. But what if the patient who is COVID-19 positive and he is having symptoms suggesting of acute appendicitis? First of all, let me ask, is it common to have co-pathologies together at the same time? We mentioned in the storming case scenario that patients come with a history or with symptoms mimicking acute appendicitis and they tend to be COVID positive. And by the way, one of these patients, or I think whom there are five patients, the one of them was appendicitis and during surgery the appendix was normal. You get my point. So he has classical picture of acute appendicitis, but during surgery the appendix is normal. So let me say that if a patient is positive and he's having symptoms of acute appendicitis, this patient is most likely is having this appendicitis as part of COVID disease. The appendix is got involved with the general with the involvement of all systems in COVID-19. But in the worst scenario, let us suppose a patient with acute appendicitis and he is positive, he's COVID positive. We do surgery for them, okay? If they can be treated conservatively and they showing good response according to the antibiotic and their pain improved and their definitely we cannot tell the temperature because it is shared between them. But the most important thing is that the pain and the GI function, they improve both of them based on the antibiotic, based on the fasting and the conservative management. That's okay. But if it's not improved, definitely we have to go for surgery because he will perforate and will have peritonitis. We have to go for surgery. And so continuous assessment and reassessment after starting with medical treatment and conservative treatment. If conservative treatment, despite appropriate implementation of that treatment fail, then we should do the surgery.
Great.
But fortunately enough, till now, up to the number of patients we saw, till now we didn't go for surgery for a patient who is acute. Most of them they respond, or all of them actually they respond to medical treatment.
Very good. Alhamdulillah. إلى الآن. So we have Dr. Muhammad Noor. I think he's having something to say. تفضل دكتور. Can unmute.
إذا ما في أنا كنت أتمنى في ناس.
مرحبا دكتور محمد، نحن سامعينك.
طيب أنا بس عندي كومنت لأنه أنا كنت أتمنى لو في واحد من انفكشن كنترول برضه كان إذا في ناس عندها اكسبيرينس في الموضوع ده. موضوع في السودان the most of OR is neutralized، يعني هي لا سالبة ولا موجبة، صح؟ معاي في الحتة دي؟
اتموسفيريك هي اتموسفيريك.
نعم. يعني الاتموسفيريك هي لا هي سيستم بتاع بوزيتيف OR، وهي دي الويرلد وايد المفروض تكون كده، ولا هي اتموسفيريك اصلا ما ممكن تكون سالبه في كل المقاييس، هي المفروض تكون بوزيتيف. طيب في زي ما قال مستر، يعني نحن في وضع زي ده اصلا الديزاين حقنا ما بوزيتيف. انا اعتقد انه يكون الهبه فلتر موجوده في كل فروم ذا ستارت حتكون مفيده جدا. والناس اللي برا ما حيتاثروا لانه هي طبعا تشتغل شغل بتاع نيجاتيف. الهبه فلتر وفي تسحب كل الهواء، ما حتشتغل لنا. في وجود البوزيتيف ممكن بعد الانتوبيشن تكون ضاره، لكن في وجود هي بيئه متعادله او اتموسفيريك يعني حتكون مفيده جدا، والناس المفروض تكون should be applied يعني في وضعنا نحن في السودان يعني حتكون مفيده شديد. بس الحاجه المهمه طبعا واشار لها المستر الموفمنت، يعني المفروض كل الاكويبمنت كل الفاسيلتي المحتاج لها وات ايفر تكون موجوده، وبعد ذاك ليميتيشن اوف موفمنت، لانه الناس كل ما تتحرك يبقى الصوص بتاع انفكشن يكون هاي.
اتس كلير.
دي الكومنت حقي، وشكرا
دكتور محمد، شكرا جزيلا. شكرا لك. So, Dr. صديق, we don't have more questions. Thank you so much for the great presentation. Very valuable, very helpful. And thank you for being with us. For our people, inshallah, في السودان يا إخوانا, stay at home, stay safe. وكل زملائنا في surgery stay safe. وكل زملائنا الأطباء ربنا يحفظكم وربنا يتقبل طاعاتكم. دكتور صديق شكرا جزيلا. Thank you so much.
شكرا لك، كتر خيرك، وشكرا للجنة أطباء الخليج نتمنى السلامة والعافية والصحة لأهلنا ولإخواننا الجراحين ولسائر الأطباء في بلادنا الحبيبة وفي سائر أرجاء الدنيا من مشرقها إلى مغربها. نسأل الله سبحانه وتعالى أن يعود علينا هذا الشهر الكريم والناس في أمن وعافية وسلامة، وبارك الله فيكم.
شكرا جزيلا. السلام عليكم.
عليكم السلام.